morning, good afternoon, and welcome to all our speakers, chairs, and wonderful audiences of the ACNS webinars. The speaker for the first session of today is one of the most eminent and celebrated personalities from the United Kingdom, Professor Henry Marsh. After graduating in politics, philosophy, and economics at the University of Oxford, he studied medicine in London, graduating with honors in 1973. He subsequently trained as neurosurgeon. Dr. Marsh's work has been subject of two major BBC documentaries, Your Life in Their Hands in 2003 and The English Surgeon in 2009, about his work in Ukraine over the last 29 years, which has won many awards, including an Emmy. His first memoir, Do No Harm, has been an international bestseller with 37 foreign editions and translations. This book was shortlisted for 8 major UK literary prizes and won both the Sky Arts South Bank Show 2015 Award for Literature and the Penn Ackerley Prize in 2017. He published the second book, Admissions, which became a Sunday Times #1 bestseller in the UK. Dr. Marsh was made a Commander of the Order of the British Empire by Her Majesty the Queen in 2010. He retired from the UK's National Health Service in 2019, and it is our great honor to have him today with us. And today he'll be talking about his experience, what he learned from 40 years in neurosurgery. The speaker for the second session of today is our honored guest from the USA, Professor Tomoyoshi Shigematsu. Professor Shigematsu is an assistant professor in neurosurgery and diagnostic molecular and interventional radiology in the pediatric cerebrovascular program, Cerebrovascular Center, Department of Neurosurgery in the Mount Sinai Health System, New York. He was a senior fellow of vascular neurosurgery and neuroendovascular surgery at the Department of Neurosurgery at the Osaka University Hospital, Suita, Osaka, Japan, and later was an attending neurosurgeon at the Ayano Miyako Hospital, Osaka, Japan. His research interests are focused upon endovascular treatment of pediatric cerebrovascular anomalies. He is a noted author with several publications in various peer-reviewed journals, and we're extremely honored to have him today with us, and he'll be talking about the management of vein of Galen malformations. The chair for the first session of today is our honored guest from Italy, Professor Francesco Tomasello. Professor Tomasello is a senior consultant in neurosurgery at the Humanitas Clinical Institutes of Catania. He was the past vice president and president of the Italian Society of Neurosurgery. He was previously a professor in neurosurgery in the Department of Neurosciences, Messina, Italy. He is the founder and the president of Italian Network of Innovations and Technology in Neurosurgery. He was elected the honorary president of the WFNS by 170 delegates of the neurosurgical societies from all over the world. In 2017, he received the Lifetime Achievement Award assigned annually by the European Association of Neurosurgery for his extraordinary contribution to European neurosurgery. We are extremely thankful to Professor Tomasello for accepting our invitation to chair the session of Professor Henry Marsh. The chair for the second session of today is our honored guest from Japan, Professor Masaki Komiyama. Professor Komiyama is a director in the Department of Neurointervention, Osaka City General Hospital, Osaka, Japan. Professor Komiyama reserves his subspecialty in cerebrovascular diseases, especially pediatric cerebrovascular diseases like hereditary hemorrhagic telangiectasia, head and neck vascular diseases, and also neurovascular anatomy. He is a very well-known research scholar and was also the editor-in-chief of the famous Journal of Neuroendovascular Therapy till last year. He is a member of Japanese Society of Neuroendovascular Therapy, the Japan Neurosurgical Society, and the Japanese Congress of Neurological Surgeons, as well as many other important international organizations. Professor Komiyama has special interest in rare diseases like hereditary hemorrhagic telangiectasia. He is a member of Global Research and Medical Advisory Board for HST and also HST Society of Japan. We are extremely honored to have him today with us to chair the session of Professor Shigematsu. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Gato, I would like to welcome all the chair speakers and the wonderful audiences to this online education platform of ACNS webinars. A warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Lubun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this podium to our first chair, Professor Francesco Tomasello.
It's a great pleasure and privilege for me to introduce Professor Erin Marsh, who is one of the most outstanding neurosurgeons in UK, worldwide recognized. He is a former senior consultant at Atkinson Morley in UK, and this is I think is very important because also I had some connection in the past with the Atkinson Morley Hospital. He studied philosophy, politics, and economics at University College Oxford before graduating with honors in medicine. He was very early fascinated by the mystery of brain and the possibility to treat brain disease preserving cerebral functions. He was a pioneer of advanced neurosurgical procedures also in Nepal and Ukraine. This is very important, especially considering the recent troubles. His activity in Ukraine was the subject of a BBC movie, The English Surgeon. He performed thousands of neurosurgical procedures, some of them in brain surgery under local anesthesia. Furthermore, he was a recipient of several awards and was appointed commander of the Order of the British Empire. The compassion and the feeling of the burden of responsibility for patients who trusted him was an important target for him. He wrote two important books, which are very much appreciated worldwide. One in 2014, Do No Harm, and the second one, Admissions, A Life in Brain Surgery, in 2017. He advocated a neurosurgical practice, staying close to the patients with great emotional sensitivity for their fears and their hopes of health. I am really very delighted to introduce Professor Marsh, who is, in my opinion, a legend of neurosurgery. And I think that we can learn much from his lesson, which is entitled, What I Have Learned from 40 Years of Neurosurgery. We are anxious to hear your lesson, Professor Marsh.
Well, Professor, thank you very much indeed. You said many kind and exaggerated things about me. It's a great pleasure and honor to talk to you all. I've had strong connections for many years with Nepal, with my late colleague, Professor Dev Kota, and I'm really delighted to talk to my colleagues in Asia and maybe elsewhere as well. I did my final operation 2 years ago on an intramedullary cervical tumor in Kathmandu, and I retired from full-time work for the National Health Service in Britain 7 years ago now, though I still teach on a regular basis. Now, one of the nice things about writing a bestseller, as I did, you get some very nice letters. And one letter I received a few years ago from Dr. Linda Hill, who runs a public health program at the University of Southern California in San Diego. And she wrote as follows: I sit in a committee with other residency directors. As you probably know, the US also implemented duty hour restrictions. They're not like the 37.5 hours of the European Working Time Directive. A number of years ago, our then head of neurosurgery came to the committee and asked for an exemption to the 8-hour-a-week rule. When the committee asked why an exemption should be given to neurosurgery and not the others, he said, because neurosurgeons are superior humans, mentally, physically, and sexually. And as Dr. Hill said, you can't make this stuff up. But here I am 42 years ago, just starting my career as an intern, as a junior houseman in neurosurgery. Why did I become a neurosurgeon? Well, many reasons. Excitement and drama, love of patient care. I was brought up by my parents to feel that it's very important to be of service. Fascination with the brain, which has actually become stronger as the years have gone by and as I got older. I've always loved using my hands, like all surgeons. Power and status, yes, I can't deny that. My wife is an anthropologist and says I'm a typical silverback gorilla alpha male, like many neurosurgeons. Money and stable employment, well, I didn't really think about that at the time, though it's something I did actually achieve. And coming back to the beginning, if climbing Mount Everest was safe, there wouldn't be a queue to get to the summit. And there's no question of the fact that neurosurgery is dangerous is part of its attraction. Like most surgeons, and maybe especially neurosurgeons, we find risk attractive. And yes, that's not entirely a bad thing, but it's something we have to learn to control and live with. And you have to remember that the smallest neurosurgical sucker has an internal diameter of 2 millimeters, and yet 1 cubic millimeter of cerebral cortex contains between 50 and 100,000 nerve cells and up to 1 billion synapses. So although neurosurgery is supposed to be terribly delicate and precise, compared to the reality of the brain, is really pretty crude. And whenever we operate on high-grade gliomas, I think we're often a little bit shocked at just how crude and rough the surgery is. Obviously very different from AVM surgery or CP angle tumor surgery. But I think there is a certain myth about neurosurgery, but it's acme of all surgical endeavor. It's not. Neurosurgery is another branch of surgery. What's special about it is it's so dangerous and there is so much morbidity. And that puts particular demands upon us as neurosurgeons. And I had a successful career. I had a certain amount of fame and power and glory and a good income as well. But I also acquired fear, shame and guilt when I made bad mistakes, and I'm only human. And in the recent years, with the increasing bureaucratization of healthcare, which is not unique to Britain, a certain amount of alienation and frustration, but I'd lost a lot of the autonomy and independence I had when I became a so-called consultant, that is senior surgeon, in 1987. So looking back on my career, it reminds me of that great song by B.B. King. You better not look down if you want to keep on flying. Put the hammer down, keep it full speed ahead. You better not look back or you might just wind up crying. You can keep it moving if you don't look down. And I think all of us in the middle of our neurosurgical careers, we have to have blinkers to some extent. If we look down and see just how dangerous, how emotionally difficult the work can be, we wouldn't be able to do it. So it seems to me that looking back on my neurosurgical career, it was like being on a tightrope, trying to find a balance between competing demands. But rather than just being one tightrope, we all have to negotiate a whole series of dimensions of balances. And the first one, of course, is finding a balance between caring for our patients and yet being detached. We can care too much for patients and make bad decisions because of that. And we cannot care enough and become cold and detached, and the meaning of our work disappears. We are, most of us, particularly neurosurgeons, fierce individualists with big egos, whether we're men or women. And we have to balance that, which is necessary. When you go into the operating room, you can't be full of self-doubt and anxiety. But surgery is above all a team effort, much more so now perhaps than 30 or 40 years ago. And we have to learn to work as part of a team and balance that against our fierce individualism and egotism. We sometimes have to find a balance between our conscience and what is best for patients and a certain amount of loyalty to the institution and obedience. We sometimes will have a colleague who isn't really, we think, that good. And yet, do you try to get rid of him? Do you blow up, do you destroy the department with a civil war? It can be very difficult. And most of us will have encountered this problem over the years in our career. You have to find a balance between medicine as a vocation of being of service, love of patients, and money. And we all know some colleagues who we think love money more than they love their patients. And again, that's another balance we have to find. We have to find a balance between being self-confident and being endlessly self-critical. We all suffer from what psychologists call the optimism bias. We all think we're better than we really are. There's this study done in America where you ask drivers, are you better than the average driver? And almost everybody says they are. And we have to have that optimism and high self-esteem. But if we are too self-confident, we will not learn from our mistakes. We'll become blind to them, as I'll discuss in a moment. And we have to find a balance when talking to patients between being honest and a certain amount of pretense as well. We have to take some of the patient's anxieties onto our own shoulders, and finding that balance can be very difficult. And part of that is, if you do a difficult operation, are you being brave or are you being recklessly stupid? And are you being too hopeful, or how do you find a balance of being realistic? When do you do a second or a third operation on a high-grade glioma? Problems like that is we want to cheer our patients up and give them hope, but sometimes there isn't very much hope, and knowing when to stop is a big problem in surgery. And lastly, we have to find a balance between work and life. My generation of surgeons, there wasn't really a balance. It was all work, and I rather neglected my family. I'm just very grateful now in preaching old age that I still have a very good relationship with my 3 children, and even more so with my grandchildren. But I put it at risk by always putting work first. Now the culture is different. My own surgical department in London has about 15 consultants. When I was there, we only had 3 to begin with, and I was operating 4 or 5 days a week. That has now changed profoundly, but it's still a problem. Patients want us to be devoted to them, but our spouses and our children want us to be devoted as well. And there can be a conflict there, and we have to find a balance. The problem of compassion and detachment, there was a book published a few years ago in England by a psychologist who specializes in seeing unhappy doctors and unhappy medical students, mainly young ones. It's a good book, it's very interesting, but she says one or two things that annoyed me greatly. Firstly, she said that all doctors have much to learn from palliative care doctors, which of course completely misses the point. The palliative care, it is palliative. You're no longer having to take major risks. You're not having to expose yourself to failure in the way we do, especially in neurosurgery. And that is why we have to be detached to some extent in order to accept that risk, even though we find the risk in some ways attractive. And doctors must stop seeing patients as other. Well, yes and no. We have to see them as other to some extent. When we're in the middle of an operation, we don't want to be full of anxious thoughts about the family waiting outside and things like that. So we have to find a balance. It's very difficult. It will depend on your personality, on your teachers, on your colleagues, on your national culture, and your age. You'll change as you get older. So many doctors say, I didn't really understand what my patients are going through until I became a patient myself. There's a lot of talk about empathy, caring. Strictly speaking, in English, the word empathy means to actually feel what somebody else feels. Now, obviously, you couldn't operate. You couldn't take somebody's blood if that was the case. And yet, if you don't have some understanding of what your patients are experiencing and feeling, it'll be very difficult to make the right decisions with them. As I said before, we can care too much for our patients, but we can also care too little. And the point is that many neurosurgical decisions are about quality of life, not just life or death. And only our patients can tell us, and their families can judge what the quality of life of their life should be. That's not our business. We have to listen to our patients and learn from them. And that's even, we think of neurosurgery as a technical specialty, but it's medicine, and medicine is about patients. And a lot of that is about listening to patients, which many of us, and I include myself in this in the past, are not very good at. We want to operate, we want to get on with things. We don't want to expose ourselves too much to our patients' anxiety and suffering. And then team working. Well, why is it relevant to decision making? Well, in one sense, a decision of whether to operate or not is simple. You say, what is the risk and benefit of operating? And what's gone wrong with that? And what is the risk and the benefit of not operating? But the point about this is these are not facts. These are probabilities. And our judgment of probabilities is subject to all sorts of unconscious biases, cognitive biases, the psychologists call them. The extradural tumor on the left is, of course, we know it's exceptional. A simple case, if you don't operate, the patient will die. If you do quickly, the patient will probably make a full recovery. But most neurosurgical decisions are not like that. Look at the cerebral hematoma on the right. Do you really know what the prognosis is for that? What sort of quality? Very difficult, no easy answers. But that, your judgment about whether to operate on that case or not, will involve all sorts of complicated, subtle, emotional factors. Is not cold reason by any means. And a lot of work has been done by psychologists. I'd all direct you to his wonderful book by the Nobel Prize winner Danny Kahneman, about how we do not often, when we think we're being consistent and rational, we often aren't. And the conclusion to all this work is a very simple, profound human truth, which is very important for surgeons. Other people are better at seeing my mistakes than I am, just as I'm better at seeing their mistakes than they are. So but a very important aspect of team working is it will make us better surgeons if we have colleagues who will criticize us in a positive way, and if we can criticize them back in return. And although in theory, we all do this with morbidity and mortality meetings, I don't know about you, but my experience of morbidity and mortality meetings is they're often not very good. And what they require to be good is really effective leadership by the senior doctors who have to demonstrate a degree of honesty, which will then spread down to the other surgeons in the department. We have to be honest about mistakes. And that actually is really difficult. It's difficult to tell patients you've made a mistake. It's also very difficult to tell yourself you've made a mistake or that things could have been done differently. It's very easy to say, well, things would have gone very badly anyway. And this is the way we have to be so self-critical at the same time without losing the high self-esteem as surgeons we require. And another aspect of teamwork is training. Yes, we all say the patient comes first and we have a duty to our patient in front of us, but it's more complicated than that. We also, as senior doctors, have a duty to our trainees' future patients who don't yet exist. And actually, those two are in opposition. So an important part of team working is training, working in an atmosphere where there's a good degree of supervision, but not too much. And one of the most difficult decisions we all have to make as senior surgeons is at what point we let our trainees make their first solo flight, their first operation on their own. They have to cross that threshold at some point. Looking back on my career, some of the worst mistakes, or some of the many mistakes I made, was liking my trainees too much and overestimating their abilities. And as a result of bad decision-making on my part about when to delegate an operation, patients came to harm. I got better at it over the years, but again, in a good team, hopefully these problems are reduced. You can never get away from them completely. And if you don't let your trainees operate, they'll never learn until suddenly they become appointed to a senior job, and then they have to learn right from the start again. And again, team working is very important for mental health. I mean, I don't know about Asia, but certainly in Europe and England, I think surgery has become a lot more stressful. There is more litigation, more management, more and more stuff in the newspapers about medical mistakes and murderous doctors. And if you work on your own in isolation, you can get pretty depressed and anxious. unless you're very thick-skinned. So if you treat your colleagues well, they'll probably treat you well, and it's hugely important. We want, in a good surgical department, neurosurgery is very stressful, but it should be enjoyable in a sense, not for our patients, but for us. And a good team is really important, that your colleagues are the best support you have when things go badly. And they will go badly, because that is the nature of neurosurgery and the risk we expose ourselves to by becoming neurosurgeons in the first place. Vocation versus money. Well, when I work in Ukraine, I'll often see many children with DIPGs. When I started in Ukraine 30 years ago, and God knows what's going to happen there now, I was doing things with my colleagues that nobody else could do in Ukraine because neurosurgery there was so behind the West as a result of Soviet communism. But now, in fact, there are some very good centers for neurosurgery in Ukraine. It's very unequal and uneven, but it's not as, on the whole, parents will get good opinions. But because I'm well known and I come from the West, parents, or desperate parents with children with hopeless brain tumors, will hope I'm the magical wizard, the magician, who will save their child's life. And they'll all come, most of them, clutching things they've printed off the internet, like this one here from Mexico, promising intraarterial chemotherapy at a great cost. We'll see the bank details are there, of course, for DIPGs. Now, it only takes a few minutes Googling to find that controlled studies show that intraarterial chemotherapy doesn't achieve anything. Now, the interesting question about these various doctors there is what are they thinking? Are they knowingly deceiving patients? Are they saying, well, controlled trials are, there are always a few exceptions? Are they thinking, well, I feel sorry for the parents, let's help them? Or are they deceiving themselves? I don't know. I don't think they're so knowingly deceiving parents. And yet there's nothing more vulnerable than the parents of a child with a malignant brain tumor. And yet it's difficult not to think the fact is people making a lot of money with this proposed treatment is distorting their estimate of the probabilities. As I said, surgical decision-making is all about probabilities. And one of the commonest problems in private medicine is we overestimate the risks of not operating and underestimate the risks of operating. You're never wrong. A weather forecast is never wrong. If the weather forecast is a 99% chance it won't rain, and then it does, well, they said, well, there's a 1% chance it would rain. And of course, you can only really judge percentages through hundreds of cases and scientific studies. And if you are going to make a lot of money from an operation, it probably will unconsciously distort your estimation of probability. And going back to self-confidence and self-criticism, there's a famous quotation, goes back centuries, in fact. The Lord Moynihan, who was a famous general surgeon, quoted it, I believe, saying that surgeons have to have nerves of steel, heart of a lion, and hands of a woman. But the problem is, of course, we're easily seduced and corrupted by the faith and trust which our patients have little choice other than to place in us. And that's something we must, although we have to come across to patients and families as confident and reasonably certain and caring, we mustn't end up believing that what they think about us is true, that we are the best and better than anybody else. And of course, an aspect of this self-confidence and self-criticism is you have to keep up to date with progress, go to meetings, read the papers. You have to understand you might be wrong. You have to keep an open mind. You mustn't have the mentality of your patients who have 100% confidence in us. And you have to know the difference between what's opinion and actual evidence-based fact. And it is extraordinary when you think about it, how much of neurosurgery is not on the basis of class 1 evidence. A lot of it's experience and opinion. And I'm often asked, what would your advice be to a young budding neurosurgeon? And I say, ask for help. To ask for help is not a sign of weakness. It might feel like it, but it isn't. It's actually a sign of strength. And I learned as a trainer, having trained many neurosurgeons over the years, that the dangerous trainees were the ones who didn't know their limitations and didn't know when to ask for help. I felt happier about slightly anxious trainees who maybe asked me a little bit too often, so to speak, rather than the other way around. But again, it's a balance. There's no simple answer to this. And as we say in English, tradition in English surgery, it takes 3 months to learn how to do an operation. I mean, I don't want to say neurosurgery is easy, but it's not that difficult once you've learned the actual technical manipulations. And now that aneurysm surgery is largely dealt with radiologically, a lot of the really difficult, delicate surgery, we don't do it very much now. And then it takes maybe 3 years to learn when to do it, but most difficult of all is to learn when not to do it. And we say that takes 30 years, by which time you're close to retirement. And then you think, is that because I'm getting old and cowardly, or is it because I've become old and wise? And I don't know the answer to that. There's another balance we have to find. And finally, nobody ever told me this, but we all know it right from the start, right from the get-go, when we start going on the wards as a young doctor. There is nothing more frightening for a patient than a frightened doctor. So we have to hide our feelings. And of course, we're often frightened, particularly when we're young doctors. And there was a great French writer who wrote epigrams, who said, the steadfastness of the wise is but the art of keeping their agitation locked in their hearts. In a modern context, we call it stress. And there are 3 ways of hiding stress. Not having it in the first place, which makes you a psychopath. And although I know a few colleagues who have psychopathic tendencies, by which I mean say they don't have empathy and don't seem to suffer when their patients suffer, they are in a minority. Most of us suffer a great deal when our patients suffer. You can hide it from others, which we all have to do, and particularly when dealing with patients, and we can hide it from ourselves. And this is a very important self-protective psychological mechanism we all have to do. I mean, if you think back to when you're a young consultant, if you don't take on the difficult cases, how will you ever get better, even though you may have colleagues who are more experienced than you are? Yes, ideally, when you have a difficult case like that, you will do it jointly with an experienced colleague. And that's good teamwork. And there's more of that happening now in British medicine than in the past. But when I became a consultant more than 30 years ago, that wasn't the case. You jumped in at the deep end and you had to pretend to the patient you knew what you were doing, you were very experienced. But we were practicing on patients, and that's inevitable to some extent. But you need to try to keep it to a minimum, and we need to be aware of the fact we often deceive ourselves and tell ourselves we're better than we are. There's a wonderful book, where's it gone, by evolutionary theorist, a very great man called Robert Trivers. And he's written a book called Deceit and Self-Deception, and he tells us how in nature, everybody, all animals and humans are all deceiving each other all the time to get an edge. We're all predators to a greater or lesser extent, or prey for predators. And deception is very important. But what's unique, of course, about human beings is, in fact, our capacity for self-deception. And he says, why is that the case? Why do we practice self-deception? And his answer is that it's easier to deceive other people if we deceive ourselves, because we're less likely to show that we're nervous or anxious or being dishonest. So self-deception, in a sense, is a necessary surgical ability. Sorry for why is it jumping all over the place? And coming back here to the hope versus realism, this is healthcare costs by age, comparing America with other European countries. On the x-axis is age, on the y-axis is cost. And there is a huge increase in medical expenses in America as people get older, even though life expectancy in America is worse than most European countries. And there are many reasons for this, but it's also about the optimistic unrealistic cultural America as opposed to Europe. And this is something, again, over-treatment is a big problem in medicine, and is something which I think is starting in Asia as well. And of course, we know this is CAR T therapy. I mean, there are incredibly expensive treatments now, $500,000 for a patient for treating relapsed leukemia. And it's very hard to see how this is going to end. There'll be more and more gene therapy, genetic engineering, all sorts of things are coming. This was a slide I was showing when I was lecturing in Houston 3 years ago at a meeting of all the neurosurgical program directors. On the y-axis is satisfied with work-life balance, and on the x-axis is self-reported burnout, as the Americans call it. And there's a fairly good linear relationship between the more satisfied you are with your work-life balance, the less likely you are to be burnt out. But there are two exceptions. One is emergency medicine, who are very satisfied with their work-life balance, but very burnt out. And the other are neurosurgeons, who are not at all satisfied with their work-life balance, but not especially burnt out. And you can read into this what you like. Neurosurgeons, we on the whole are highly motivated. We're attracted by risk. We're fascinated by the brain. It's a kind of all or nothing relationship. And yet burnout is potentially still a problem. And a certain amount has been written about it now. It's a big issue in American training programs, probably less in Asia. In England, don't know. But having said all that, and I said earlier that I have experienced periods of great shame and guilt and fear, I have absolutely no regrets. I would not have wanted a different life or a different career. This is a child I operated on about 3 or 4 years ago in Ukraine, or helped operate, for a straightforward cerebellar parasitic astro. And she did very well. And there's an enormous satisfaction there after the operation to stand at the cot side with colleagues I've been helping and training to have saved a child's life. It really is, it's a fantastic privilege. As the years go by, you no longer feel terribly excited or pleased with yourself because you think of the disasters. And the next child I operated on at that hospital died from a catastrophic post-operative hemorrhage, was a medulloblastoma. I hadn't looked into the post-operative care properly. There was a hospital I wasn't very familiar with. There was no proper post-operative care. There was no pain management. Blood pressure control was non-existent. And she had a terrible hemorrhage. She ended up locked in and fortunately died. So the point about neurosurgery is that triumphs are only triumphant because there are disasters. As with climbing Mount Everest, if there weren't, I don't know, 170 dead bodies on Mount Everest, not that many people would be interested in climbing it. And we have to learn to find this balance between the enormous privilege, the joy, the glory of brain surgery and its dark side. And part of a dark side is us. It's our fact we're human beings. We are not superior people, unlike what that San Diego neurosurgeon said. That's a mosaic in Greek lettering, although in a Roman ruin. It says, Gnothen se auton, know thyself. So I suppose what I learned from 40 years of neurosurgery, I learned a lot less about the brain than I expected. All I learned was we understand very little about the brain. But I learned a lot about myself and my colleagues. And I think above all, I learned how I think modern surgery is all about teamwork, or struggling to work well as a team, despite all the ambition we have as fierce individualists. Thank you very much.
Thank you very much, Professor.
Amazing presentation, Professor Marsh.
Oh, thank you.
No, it's really a similar experience for most of us. I would like to tell you, we lost very recently a very good friend and outstanding neurosurgeon, Fred Gentili. One of his sentences was, quality of life is more important than life itself. So this was his message, but also I saw that we have the idea to perform always radical surgery, especially with the tumors. In your life, there was a change of attitude to radical surgery, depending on the risk for the quality of life of patients. This is very important as a message for young people, because they probably at the beginning, and this was my experience at the beginning of my career, I did not care enough about the quality of life, not about the result, but about the quality of life. So I would like to hear your opinion on this, because you spoke about failures, and we need also to have a self-criticism. You're right.
Well, I started doing, I was the first surgeon, I think in Europe, to do awake craniotomies for low-grade gliomas, although there was a chap, Rutger, I think, in Munich, who was starting to do them as well. I learned the technique from my American trainees, from George Ogerman, who was really doing it for epilepsy. But Mitch Berger, who then went on to UCSF, he was doing them for low-grade tumors. And it seemed to me a very logical thing to do. We were starting to diagnose low-grade gliomas early on because of the wide sudden availability of brain scanning. And the traditional treatment in Britain and Europe was to tell the patient, oh, well, you have a brain tumor. We can't operate on it. Wait, come back when it's cancerous and then we'll operate. More or less that was it. And that struck me as highly unsatisfactory. But I started operating on a few small ones. It's very easy under local anesthetic. It's not a big deal. I think my team were the first people to use propofol. Before then, it was droperidol and fentanyl. But I then started taking on bigger tumors, doing very radical right frontal lobectomies, and the results actually were not good. And you got all sorts of subtle psychological, social changes, which I'm very puzzled by some of the advocates now for very radical supramarginal resection. Yeah. A lot of these are frontal tumors, and the patients can't tell you themselves if they have problems. You learn that from the family. And if you don't have a good relationship with the family where they will be honest with you, you won't really understand what you may or may not be achieving. And since most of these low-grade gliomas do grow back eventually, we really have to be very, very careful. But the technology has come along a lot. I mean, my colleague I trained, who has taken over my low-grade glioma practice, has all sorts of fantastic neurophysiological monitoring, and he does insular tumors, which I was very reluctant to do. But still, talking to the patient and listening to the patient and family remains a very, very important part of deciding just how radical you should be. I've read some extraordinary case reports from America advocating radical surgery for butterfly gliomas, and so saying that, you know, it's amazing what patients are willing to undergo. Yeah, patients will undergo anything if you say it will save their life. But if you're not honest with them about what the consequences are. So it's all about human decision making. It's not technical, a lot of it.
Yeah. Thank you so much. This is, I think, is an important message for young neurosurgeons.
Yeah, very much so. And I mean, again, when we're young, we're enthusiastic. We want to climb mountains. You know, we have to. But it's important, again, if you have a good surgical department, the older doctors will hopefully slow down the younger doctors a bit, just like the younger doctors will energize the older doctors. It's a balance.
This is also my experience. If I go back to the beginning of my career, I had only mostly certainties, and later, more and more, doubts.
Exactly. Exactly. And yet, with patients, we have to be very careful the way we express and share those doubts, because one can end up terrifying them, you know. So again, there's a great art to talking to patients well.
Okay.
All right, thank you.
Thank you very much, Professor Tomasello and Professor Henry Marsh.
It's a
It was a
pleasure.
great honor to have you with us today. We have learned a lot from your books, and we have read it over 1,000 times. We have quoted you 1,000,000 times. We have no words to express how thankful we are to you for coming here and sharing your thoughts with us. Thank you very much.
I wish you all a success with you. I hope when you finish your careers, you look back at it with the same sense of privilege that I have, even though it was often very painful. We are lucky men, lucky women to be neurosurgeons. We really are. But it comes at a price and with a very strong duty to think very carefully about what we should do.
Right. Thank you very much. With that, we'll
good luck.
Thank you very much. We move on to the second session. I would like to inform our viewers also that there are currently 1,100 people who are watching us live in this webinar, and we're extremely grateful to Professor Shubin for broadcasting this across China on the WeChat channel. So that we'll move on to the next session, and I would like to invite Professor Komiyama to say a short introduction.
Okay. It's a great pleasure for me and also honor to introduce Professor Tomoyoshi Shigematsu. He's working these years in New York with Alex Bernstein. Every people knows Alex Bernstein. He is famous for the care for vascular malformations. I believe Professor Shigematsu has a great experience with Alex for the care of such pediatric cases. And today, I'm very much excited to listen to your lectures. Tomo, could you start the lecture?
Right, great. Thank you, Kamiyama Sensei, for such a nice introduction. And I would like to start sharing. So I hope everyone can see my screen. So yeah, I had never imagined that I was going to give a talk about pediatric topics in early 2010s when I was in Japan. But yeah, here I am. And thank you, Dr. Komiyama again. And thank you, Dr. Zuraha and Nuri for giving me this opportunity to present here. I'm very anxious to talk after and in front of such the legends in neurosurgery here, but let me try. But again, I'm Dr. Tomoyoshi Shigematsu, relatively young, probably, and one of the neurosurgeon and neuroendovascular surgeon in Mount Sinai, New York. I treat pediatric cerebrovascular cases here with Dr. Alejandro Bernstein, Dr. Fifi. I have no COIs to disclose. So when Dr. Nuri, he was my former co-fellow at Mount Sinai, and I think he's a committee of ACNS. And when he told me to give a talk about vein of Galen malformation and other AVF, initially I thought I should give a review or a systematic talk, but I realized that any textbook does that, any usual pictures does that. So this time I would like to talk from a practical standpoint. I hope this will help people if you face this real vein of Galen baby all of a sudden someday in the future. And as a matter of time, I would focus on vein of Galen this time. I probably don't have any time to discuss about the other AV fistulas. But just for a reminder, I'll quickly review the vein of Galen malformations. So initial reports for treatment of vein of Galen aneurysmal malformation were from 1940s, and they treated with carotid ligation. Beautiful pictures, as you see here, were published, and ectatic vein in the midline with arteriovenous shunting were described. And it took another 40 years until Dr. Rabel mentioned about the concept of the arteriovenous shunting on the median vein of prosencephalon, the vein of Markovsky, which is not the actual vein of Galen, but its precursor vein. And now Doctors Lashanias, Brugge, and Bernstein have published this famous textbook, and the concept has established, I think. This image is from the surgical neuroangiography, and this shows the choroidal feeders that usually involve in the fistula, and the fistula located in the subarachnoid space in velum interpositum or quadrigeminal cistern. In Japan, my chair here, Dr. Komiyama, has published a similar textbook. I really like it. And the concept of the classification of the vein of Galen aneurysm malformation, such as choroidal or mural, is very clearly described, as well as the vein of Galen aneurysmal dilatation concept. Here I am showing the example of the choroidal type and the mural type. As you see from the side in the middle here, the fistula's point is a little bit posterior in the mural type. And the genetic research is making progress very, very slowly though. The famous mutation of the other disease are also seen in some of the vein of Galen malformations babies, RASA1, ENG, RASA1 from capillary malformations, and ENG, and the other from the HHTs. But I know that we need to work on the basic research more. Talking about the prevalence, it is well said that less than 1% of all the arteriovenous malformation in the brain. And recently from Germany, this data came out, 1 out of 58,000 live births. It's very informative. It is frequently said that accounts for 30% of pediatric vascular malformation, but I'm not quite sure if this number is correct, but it occupies the majority of the pediatric cerebrovascular malformation for sure. And if you compare to the famous congenital metabolic disorders, the prevalence or frequency of the vein of Galen malformation is not that rare probably. And so you may come across all of a sudden in the very near future. The presentation is different depending when the baby comes to you, as you know. So the vein of Galen malformation can be diagnosed during the routine screening of the pregnancy or workup of high drops. In neonates, during the workup of heart failure, of course, and in infants, workup of failure to thrive, increased head circumferences, failure to meeting milestones of developmental retardation, or hydrocephalus. And afterwards, I would say mainly incidental, but also present with developmental delay, seizure, or hemorrhagic strokes. To make things simple, usually neonates with heart failure has choroidal type, and infants with hydro has mural type, but of course, not always. And I don't think you can manage the vein of Galen baby by yourself. the key for successful management of the vein of Galen babies is a teamwork, and a team with multiple specialties, like listed here. And please include the parents in the team. In this team, we are here, and we need to be the conductor of this team, or a leader, I believe. And another thing is we need to be the main person to communicate with the parents, and when the kid is getting bigger, with the kids. So that's our primary role in this team. And based on that, let's talk a little bit more specific and practical. In fetal ultrasound, they found a large hypoechoic structure in the middle of the brain, the fetal brain, and Doppler shows arterial flow in it. And you get the consult, or you see the patient, what we should do, what you should do. Usually, the dilated vein of Galen is detectable around 20 weeks of pregnancy. But what would you do for these kind of patients? Well, we would like to get a fetal MRI. Nowadays, we can get these very clear images. This is mainly to confirm the diagnosis and evaluate the brain and check the ventricles. And based on the MRI, we can explain the details to the parents and family and give a plan. Okay. And recently from Boston, they reported the size of the straight sinus or the Felton sinus in this MRI is very, very important to evaluate or predict the risk at birth. Like if it is bigger than 5.2 millimeters, the baby is at the risk for either need treatment in neonate or have brain damage at birth. I think they are using this as one of the factors to decide the indication for fetal treatment. But still, I still think a little bit more confirmation updates are needed, I think. Well, so during pregnancy, when you need to follow the vein of Galen case, main people you need to communicate with are high-risk MFM, the OBGYN doctor, and the cardiologist, as well as the NICU doctors. Additionally to the basic monitoring, of course, of the mom and the fetus, we need to make a plan for delivery. We want the baby as big as possible. It is sometimes reasonable to perform C-section scheduling wise, but there's no evidence whether C-sections are better than the vaginal delivery or not. I personally feel the baby born vaginally does better, but maybe because the baby is good, so they can deliver vaginally. So the fetal cardiac echo is very important and done by this cardiologist. The actual cardiac function is shown, and they give the numbers based on the size of the heart, probably maternal digoxin can be started. The mom needs to be admitted for this to stabilize the blood level. We published saying that the severe heart failure cases could end up in severe brain damage. If we select right cases, intrauterine fetal intervention like transtocular direct vein of Galen embolization trial, the ongoing in Boston, could be very, very helpful, I believe. And we need to notify the neonatal intensive care unit doctors and asked to present at delivery, obviously. But besides that, we had a good experience having them involved in the devastated, very, very hard case. Like I'll show the fetal MRI here from 25-week mom and the baby week 25. You see the vein, dilated vein of Galen here. And because of the high drops, the OBGYN obtained repeat MRI on 29 week and showed like this, the significant brain damages as you see here. In the case like this, we and the MFM, of course, explained to the mom and the family what the prognosis is. But actually, the NICU team handles the palliative time after the delivery. So the baby passed in 48 hours after birth in mom's arms, and NICU helped the time, the family with the baby. Okay, so that was the antenatal management. So neonates, you see the baby who you know from the fetus, or a new baby found to have a vein of Galen during the heart failure workup. And we need to decide if we proceed the embolization or not. So here we need to work with NICU and cardiology mainly. Again, the NICU team needs to be present at delivery, and they need to immediately evaluate to figure out if the baby needs to be intubated or not. And here we really need to emphasize that they need to place the umbilical catheters. We really emphasize that. 2 3.5 French umbilical artery catheters and 1 5 French umbilical vein catheter. But we don't want to puncture the femoral artery, knowing that the baby will need multiple intervention in the future. So we really strongly ask the NICU to obtain these lines. And just additionally, and probably it's good to educate to put the stethoscope on the baby's head routinely during the heart failure workup in the newborn. You'll hear the breath, and you'll see the pulsation in the neck. In cardiology, does the echo immediately. It's very, very important information. In neurology, see and examine the patient, get the baseline NPs in your surgery. We are the part of it, but they get on board just in case of complications. And we are the one watching the MRI. We get the MRI, MRA, and MRV of the head. As you see here, we can evaluate the brain, ventricles, and the vascular structures like this. And usually, MR angiogram is very helpful to plan intervention. We won't need a full angio if we have this information at the beginning. And so all of these evaluations, cardiology, NICU, and MRI needs to happen within 24 hours, or at least within 48 hours after birth. So our indication of embolization here, embolization is maybe a little bit aggressive. If you confirm minimum or no damage of the brain in MRI, and if there is a in the cardiac echo, if there is diastolic reversal flow in the distal aortic arch, which means the baby will likely deteriorate. We don't wait. We don't hesitate. We don't hesitate to take the baby the day after the delivery or the day after, like within 2 days. But surely it is reasonable to use the visit score, of course. You probably remembers the numbers. But for us, if the baby does not have reversal flow, no respiratory issues, no respiratory support, and the baby is feeding okay, then no treatment. And to bring the baby out of heart failure, if the baby has, maybe we need to do multiple procedure. We may need to bring the baby back to the IR multiple times. So that's the neonates. So what about after 1 month? After 1 month, the presentation is a bit different. Maybe you know the patient from the birth and you're following and they stay normal, they develop normal, or they can get symptomatic, or maybe some can get diagnosed during the workup of these symptoms. Here you are mainly working with pediatrics, pediatrician or pediatric neurologist. They follow the developmental milestones, head circumferences, weight, and any symptoms. And don't forget about normal routine checkups and management. The babies always get cold. That happens. And if the baby get discharged from with the cardiac medication, the cardiologist will manage that. And we have a plan or protocol to monitor the brain, to monitor the ventricle size and periventricular calcifications. We use CT scan, and we don't trust ultrasound. So the first embolization in infants usually would be in 6 to 8 months in our practice if the baby is asymptomatic or in medically manageable cardiac condition. But I think this can be a little bit earlier, like 4 to 6 months, of course. And if any symptoms like listed here come up, then we are forced to proceed embolization earlier. We also have in mind that the procedure would usually be every 3 to 6 months for the first 2 years. And if symptomatic, we question ourselves if the ETV would be helpful, or if the treatment needs to be very aggressive and frequent in short term, like 3 procedures in 2 months or so. All right, so here let me remind you about hydrocephalus in Galen malformation cases. This condition is mainly hydrodynamic. It's hydrodynamic disorders. Basically, the CSF cannot get absorbed because of the venous hypertension. So we should proceed with embolization instead of BP shunt. Yeah, that's what it said here. And the shunt itself has a high risk for hemorrhagic complication. It's like 43% in our cohort. And in selected cases like mass effect on the aqueduct, ETB might be a good option. This is a symptomatic hydrocephalus case. It's shown here. We treated just with embolization, and the hydrocephalus resolved, and the vein of Galen is cured. It's pretty impressive change of the ventricles without any direct flow diversion of the CSF. After 1 year old, usually it's continuous care of infants or incidental finding, I believe. Of course, the delay in seizure and hemorrhagic strokes are reported, but not frequent in our cohort. Very similar team members as infants, mainly pediatric neurology and pediatrician. All right. So rest of the time, I would like to discuss the actual endovascular treatment. Okay, so let's go for the details. So for the neonates, we do transumbilical, like shown here. Yes, so these are the lines, two umbilical arteries and one umbilical vein. And we exchange one of the arterial catheter to the sheath, the forefront sheath. The pterygium sheath is also fine, but we usually use argon long sheath. And this is the X-ray picture of the umbilical axis. And we use almost pure glue, and with systemic hypotension. So for this, we need help from anesthesiologist. Okay, and it is almost impossible to close the whole fistulas, and it's very dangerous. We need to think about radiation, contrast, fluid anesthesia in one session, and because of the fragile premature germinal layer and perfusion pressure breakthrough, like acute cerebral edema, subarachnoid hemorrhage, IVH, or thalamic or other ICH could happen if we close the fistula too much. So it is very sensitive balance of the risks and benefits or effectiveness of the procedure. And the aim of the embolization is to close the fistula, not the feeder. So we come as close as to the fistula as possible and penetrate the NBCA to the venous side. This is the images of glue or the video of glue injection. Keep injecting to close to make sure we close the fistula, but not entire malformation. In some other teams, coils and onyx are used, I know. It is very effective. The coil here, onyx, then coil here and the onyx. It is very effective to reduce the flow in the vein of Galen malformation, and the baby comes out from the cardiac failure very nicely. But insufficient occlusion of the fistula, we believe that recruits small vessels and angiogenesis like this, and it's going to be hidden behind the onyx cast. This makes the further treatment in their later age very difficult and higher risk. So we prefer not to use coils or onyx, mainly coils. That's a little tip from us. And for bigger babies, all the procedures are under general anesthesia with A-line and we use neurophysiological monitoring when we go for the perforators, or maybe all the cases. And 4 French or 5 French system is usually used, and always transfemoral access if there is. And recently we like to use the 5 French radial sheath in the groin. It's thinner. And as our team reported previously, staged transarterial embolization using NBCA is the golden standard. The goal is to have the kid keep up with the normal development, so we really don't want any complications. We go very, very slow. In this case, so first we'll try to find where the fistulas are. Probably one here and one here. And we try to figure out how to get there. Probably this ACA is a good route, or maybe this big PCA will give a good access there, or maybe this tortuous route and this another tortuous route. And there are many small vessels, so usually they can't be done in one session, as you can imagine. So we do little by little. In these relatively large feeders and fistulas, detachable tip microcatheter is usually safe and very effective and useful. You see the glue injection here. Yes, and we get the good occlusion of the fistula. And for these kind of tortuous small vessels, of course, flow-guided microcatheter is necessary, we believe. There's an injection, take out, try to not to reflux too much. And we have to dilute the glue a little bit if we're closing the small vessels or the small fistulas to penetrate further. Again, we do little by little, maybe like 2 or 3 glue injections in each sessions. And after the procedure, we keep the patient in the pediatric ICU for 24 to 48 hours for close monitoring. Nothing is supposed to happen, but if something happens, things need to be done quickly and the signs cannot be missed. And strict blood pressure control is to prevent hemorrhagic complications. And I don't know why, but things often happens around 36 hours after procedure, but I don't know why. Lastly here, here's the angio after multiple transarterial embolization of the choroidal vessels that I showed right before. And there seems to be no safe arterial access to the malformation. Then in these cases, what should we do? Should we just leave it alone since if the patient is asymptomatic? Or if we treat, how do we treat it? So I reviewed our cohort. I reviewed the last procedure in our cohort. So we were able to finish the treatment. We were able to cure the vein of Galen with just transarterial embolization of the choroidal feeders in 80% of this cohort. The case I showed in the previous slide was very small residual. So that case was treated transvenous with coiling, just coiling with the fiber coils. It went well and it went away. And recently we found transvenous pressure cooker technique that Dr. René Chapeau introduced is very useful and safe as well. And we reported the technical report. And interestingly, some cases develop dural anastomosis and it grows during multiple sessions of TAE. And those cases can be treated using EVO embolic material through the dural feeders. But another interesting things are these dural anastomosis can also go away in other cases with just the transarterial embolization targeting the choroidal feeders. That's very interesting. So once we close the malformation, those anastomosis goes away as well. And we found that radiosurgery is also an option to patients with no access to the malformation like this. You can't get there. So like the malformation like this received radiosurgery and was cured. So there are several options. I think that's about it, but every time I talk about vein of Galen, I like to summarize like this as a simple take-home messages. So arterial venous fistula in the median vein of prosencephalon. This is a vein of Galen malformation, and it has a choroidal type and mural type. And treating vein of Galen malformation is a teamwork, and you need to be a good conductor. Staged transarterial embolization is the gold standard, and targeting the fistula is crucial. Not just the feeder. Try to get the fistula, and if you see the hydrocephalus, don't do the shunt, but try the embolization first. This is it. Thank you very much.
Thank you, Thomas. Excellent lecture. I quite enjoyed the lecture so much. And probably audience, and also I have several questions. Can I ask some questions to you?
Sure. I hope I can answer.
Okay. You emphasize the occlusion of the fistula sites. So you prefer the high concentration glue embolization, but alternatively, coil onychus and the other options. But I prefer, like you, the high concentration glue. And probably coil onychus will result in the proximal occlusion to the real fistula sites, which will result in the recruitment of the dural feeders or pyral feeders and so on. So in order to treat the high concentration glue in the initial steps, for example, for neonate, you use usually flow-guided catheter.
We usually use the flow-guided catheter, or recently we started using, for these 7-8 years, we've been using the detachable tip microcatheter, even in the neonates. So we can, we less worry for getting the microcatheter get stuck. So we can reflux enough to achieve the complete occlusion of that fistula, that large fistula. That's very, very useful. And we found that safe. Yes. Okay. And having the systemic hypotension is also the key, I believe. So we have to have a good relationship with anesthesiologist, and they need to we want them to understand why we need the hypotension for a certain period while we're injecting the glue. So once we started mixing the glue, we tell the anesthesiologist to to alarm the anesthesiologist that we're gonna glue soon, and then they're gonna start bringing the blood pressure down. And then when we are actually ready, the blood pressure it's in the very low range, like systolic 50s or 60s. Yes,
Okay.
that's another point.
Mhm. Well, you showed a very beautiful picture with 3 catheters to the umbilicus, 2 umbilical arterial catheter, 1 umbilical venous catheter. But for my understanding, to prevent infections, we have to remove all the catheters from the umbilicus within, for example, the 10 days. So 3 thick catheters really actually necessary for interventions. I think at least 1 UA catheter is important. What do you think?
Yes, of course. It's better to have the catheter and umbilical. If you have that, you don't need to get the A line from the wrist to the radial artery or any other A lines during the procedure, and you will have the central line in the umbilical vein. So that's very useful. Of course, infection is worrisome, of course. So we really try hard to treat or complete all the session of the intervention within a week or so. Even if we need a 3 treatment, we evaluate daily for the baby and then assess, and we do the first treatment in day 2. And then we bring the baby in the 2 days afterwards. If the cardiac echo doesn't show any improvement, then we'll want to try to push earlier, because I agree that we will have to worry about the infection. And we leave the actual 4 French sheaths in the umbilical site until we confirm that the baby doesn't need any more intervention. So yeah, I agree. For 10 days or so, it's very, very important timeline that you have to be mindful.
Mm-hmm. Tomo, you show the transvenous embolization after several sessions. How do you have the confidence that transvenous embolization does not cause subarachnoid hemorrhage? How do you identify, is it okay in this case to transvenous embolization, or other case very dangerous to do that? How to differentiate the two?
That's a very, very good question, and I don't think I have a good answer. But so basically, transvenous is dangerous, I believe. It has a higher chance of the bleed than the transarterial embolization, of course. But if there's no so we prefer the transarterial embolization. So if there's no transarterial access, and then we need to treat the vein of Galen malformation, so then that's the case. We need to pick the transvenous option, I think. So, and by that time, the vein of Galen malformation should be very, very small, like I showed, and like just a few coils can close the whole malformation, or if there is some fine vessel network or the angiogenesis around there, you can add a little bit of onyx retrograde, those pressure cooker, to penetrate those small vessels to prevent like a rupture of those fragile vessels. That's our concept of the pressure cooker technique. But yes, if we can avoid the transvenous, we would avoid.
Okay, thank you, Tomo. There
Thank
are
you.
some questions for the audience.
Yes, I would like to ask one question to Professor Tomo Shigematsu, that in patients with hydrocephalus who need immediate treatment, a diversion of CSF in whom which is invariable. What do you think about your views on a temporary ventricular access device like Omaha reservoir or probably a subgaleal shunt? What are your views on that?
if the baby has open fontanelle, in those cases, the fontanelle tap helps very, very well actually. So temporary, if that's the hydrocephalus is associated with any complication of the bleed, that acute, very, really acute hydrocephalus can be, of course, in those cases, they need a EVD. Is also reasonable. But if the patient is just irritated, not eating so much, not vomiting, but doesn't have good appetite, those symptomatic hydrocephalus, we can put the energy tube in and give a try for the medical management, and in the meantime we'll do urgent embolization. And usually after the embolization, if we do a little aggressive in those cases, we reduce the flow, and after reducing the flow, those cases symptoms improves. It's very impressive actually if you see the patient. So unless the baby really needs acute CSF diversion as EVD or fontanelle tap, still, I think the embolization is the way to go.
Thank you very much. Yes, my co-host Liu Bun Singh, any questions from you?
Thank you, Raja. Thank you, Professor, for a very nice talk. I have two main questions, Professor. First, regarding the evolution of imaging, and you mentioned that you still use CT scan for follow-up. What do you think, in your opinion, regarding a 4D flow MRI? Would the information good enough as compared to CT scan? Second thing is, Professor, those by angiographically considered cured patient, what are the follow-up like? Will you still follow up, and what are the consequences in long term? My last question, Professor, you list down pediatric neurosurgery or neurosurgeon as one of the team member. What can surgery offer in those cases? Thank you, Professor.
So for the new pediatric neurosurgeon, so it's basically the management of the CSF. So in the case we really need actual EVD or fontanelle tap, or eventually maybe if we can't manage the hydrocephalus with the embolization, we have those cases, we need to ask the neurosurgeon. Oh, I personally can't do it by myself, but we need to ask the neurosurgeon to do the flow CSF diversion, that's VP shots. That's the main role for the pediatric neurosurgeon in the vein of Galen malformation, I believe. And I'm sorry, that's first.
The second one on the DSA, cure by DSA, what the follow-up like?
Yeah, the follow-up, usually after we confirm the complete occlusion or near complete occlusion, we repeat the angiogram in a year or two to confirm the cure. So in that case, we're not gonna do any more angiogram, but we usually have the plan for getting an MRI in the, like, when the patient get 10 years old, 15 years old, we do follow up clinically with MRI. So we get the baseline MRI when we confirm the cure, and then we follow up with the MRI afterwards, no angiogram. And the CT scan, right? The CT scan, you mean we use a CAT scan for the follow-up after the neonate in the infants, like 1 month, 2 months, 4 months, just to check objectively the size of the ventricles, or to pick up any calcification of the brain. That means the patient has the venous hypertension, but like those things. And of course, MRI is useful, but MRI takes time, and for the babies, below 2 years, they really need the general anesthesia for the MRI, right? So we have to, we would prefer to avoid the general anesthesia if unnecessary. So if we want an MRI, we will do the MRI in the same anesthesia as our treatment. That's how we get the MRI in those in this population.
Thank you very much. We can invite comments from Professor Tomasello, who is a very experienced neurosurgeon as well. Professor Tomasello.
I think that this discussion on the diagnostic protocol for follow-up is very, very important because we are talking about children, so we need to know exactly what happens in the later follow-up of these patients. So I appreciate very much this idea to have a follow-up, a diagnostic, an imaging follow-up after some years, but also in the long-term follow-up. This is absolutely very important. I agree with a protocol which takes into account the long-term follow-up because we don't know exactly what happens in the long term. So I think this is very important.
Thank you very much. We can wind this session now. We can invite our final concluding remarks from Professor Komiyama.
Yes, thank you. We enjoyed and also learned so much. And your lecture will reflect our daily management of this rare vascular disease. Thank you so much, Tomo.
Well, thank you very much. With that, I would like to wind this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Henry Marsh and Professor Tomoyoshi Shigematsu, and the chairs, Professor Francisco Tomasello and Professor Masaki Komiyama, for their time and support for the educational activities of the ACNS. A special thanks to Professor Shubin for broadcasting today's webinar on WeChat channel in China. And as of we have around 1,100 neurosurgeons who have watched us live. A special thanks to my co-host Dr. Lupun Singh from Malaysia for joining in today. So until we all meet on coming Saturday, it is bye-bye from all.